Hello. In the interest of time, we'll get started. Maybe we'll start off with some introductions first, and I'm so happy at least a handful of people, because I know some sessions are running behind time, are here. And this is a session exclusively concentrating on ophthalmic trauma, and later on I have a presentation of what ophthalmic trauma is all about. We all know about ocular trauma, but ocular trauma is not synonymous with ophthalmic trauma. So I thought I should mention that as such. Actually, can you open my presentation? But before we go any further, maybe I'll have just go around of people in the audience. Just introduce yourself and what aspect of trauma you do and what aspect of trauma you wish could be done better. Maybe we'll start off with you. Can you introduce yourself? And yeah. And you say because you don't get much trauma because? Exactly right. So in other words, it's not that trauma doesn't happen, but it's going somewhere else. Do you take the trouble to go to Lahore General Hospital and help them out? Good, that's a point. Okay, so this one is going to take home messages presentation. Sir, do you want to tell us about your experience in trauma and what do you think? Where do you think we can do better? I know you must have a lot of experience.
Saudi Arabia. Presently, I'm working in Karachi,
Right.
In an ophthalmic institute, but I don't come across a lot of trauma.
Right.
I do, but not like in Saudi Arabia,
Right.
because there the traffic accidents were huge. Okay, and out of 100 patients, 40 would come to your clinic somewhere
Right.
or other, which include anything, rupture of globe and all that trauma, to the cornea, to the sclera, retina, everything. So it had to be managed well. If you can solve it there, okay. Otherwise, you send it to someone else, because the people there sue you very fast.
Right.
Okay.
Right. So since the Prince of Pakistan is here, I think it's about time to start. And I thank you all for coming to this ophthalmic trauma symposium. I bring you greetings from the Singapore Society of Ophthalmic Plastic Reconstructive Surgery. Nice to see a fellow Singaporean there, same blood, who's ocular plastics as well. More importantly, this is being done under the aegis of the Asia Pacific Ophthalmic Trauma Society, and I represent both the trauma and ocular plastic groups as well. Can you go to the next slide? So what is ophthalmic trauma? I told you it's not ocular trauma. And what's the difference? Ocular is just the globe. And enough is talked about corneal lacerations, corneoscleral lacerations, vitreous hemorrhages, retinal breaks, so on and so forth. But oftentimes we don't realize it's the same victim who's affected, where the lid, the lacrimal, and the orbit is also affected, and not just the orbit, the facial skeleton as well. And putting those two together is where ophthalmic trauma really comes in. And if you look at us as a group, as ophthalmologists here, we claim ourselves to be corneal specialists, cataract specialists, retina specialists, so on and so forth. But what we are actually forgetting is we are all ophthalmologists. And that's where the ophthalmic trauma really comes in. This is one specialty like oncology, which brings all our subspecialties together. In fact, we've gone further on. This is the only ophthalmic society where we managed to get allied health in. Today, I went to one of the local institutes over there where we talked about optometrists, we talked to orthoptists, low vision specialists, and social workers, because they're going to play a huge role in rehabilitating, counseling, preventing advocacy in the community, in the waiting rooms as well. So the take-home message for at least those of you who are interested as ophthalmologists, think ophthalmology beyond the globe itself and start working as teams so that we can deliver our patients together. And that brings us to this 12-year-old society, which is the Asia Pacific Ophthalmic Trauma Society. There are a lot of trauma societies in the world. There's a Chinese society, Indian society. There used to be an American Society of Ocular Trauma, but we were the first Asia Pacific Ophthalmic Trauma Society. So much so that we made the Americans change the name of the society from American Society of Ocular Trauma to American Society of Ophthalmic Trauma, bringing all subspecialties within ophthalmology together. And that's the website. And we have members from 26 countries. And although it's an Asia Pacific society, we have members from all across the world. And why is that important? Because trauma happens everywhere. And people say in the developed countries, we don't see much. That's not true because they're all funneled to centers of excellence. And actually, one of the deficiencies of a developed country is that because most residents don't see trauma in a developed country in their institution. So actually, they're poorly trained. So much so that they are given a trauma patient, they do manage them quite badly. And during the webinar era, we've been doing a lot of webinars. Professor Hussain Kakan, Professor Amir Awan, Dr. Farzad Paktel, all of them who are here, have been contributing to a lot of our trauma symposiums. And one of the important things is we do what is called the International Globe and Adnexal Trauma Studies, called IGATES. You can go online and look it up. This is now open to everywhere in the world. You just log in and register your institution, a person of contact. It's a free online place where you can actually upload data anonymized. You take responsibility for the data. You have to have your own ethical approval, where you can, whether you do cornea, retina, peds, plastics, neuro-ophthalmology, or oculoplastics, you can actually feed in data. And the advantage of data is that we are now able to generate manuscripts where if you made significant contributions, you become a co-author to the manuscript itself. And we are even trying to redefine trauma terminologies. Dr. Tawfiq is going to talk about trauma terminologies. We're now trying to redefine and probably create new knowledge in the field of trauma. So why should you join Asia Pacific? Number one, we are ophthalmologists, all of us dealing with trauma. We want to serve our patients better. That means you have to walk across to the general hospital, not sit in an eye hospital and say, I'm treating my ocular trauma patients. We want to generate data so that we can analyze and do better management prospectively over the years. We want to learn from each other's follies and advantages and disadvantages. We want to prevent trauma by advocacy. And that's why getting your social worker involved. And bottom line, we all care. And with that leads us to the beginning of the symposium, where we have a star group of speakers over here. I have my fellow chair, Dr. Hussain Kakan, Dr. Amir. Please, can I have you come up here, sir? Two stars of Pakistan ophthalmology. They are close allies and accomplices to the crime I commit in organizing these symposia. Yes, exactly right. By two powerful princes of Pakistan, Dr. Tawfiq from Egypt, who's going to talk to us about trauma terminology, Dr. Farzad Paktel from Tehran, who's a very passionate, committed teacher and a publisher, Dr. Amir Al-Amir, you probably know him. Yeah, he's a great leader because he's been conducting a whole bunch of Middle Eastern Ophthalmic Society meetings. A dynamic leader, and Dr. Karl Golnick, who could not be here physically but has given his presentation. And I bring you greetings from the other speakers who could not be here. So with that, I give you Dr. Tawfiq to take us forward in the field of terminology in ophthalmic trauma. Thank you.
So thank you for this great invitation for the great society. But first of all, when we are talking about trauma, we don't have a specific language to speak to each other. So if you have a case of trauma in your clinic, definitely 90% of all of us will call we have a rupture group. Am I right? This is not true. The terminology of rupture group, it's not meaning a specific point. So we need to know what is the trauma terminology, because in a researcher way of view, in a communicating way of view, you need to specify the trauma that you have in your clinic to have the same language all over internationally, even in a researcher purpose of view. Do you have a presentation ready? Mohammed Tawfiq. You don't have it? Yes, I uploaded. Yes. You can search for Mohammed Tawfiq. It's in my room. No, so it's no. I can take it from. Okay.
No problem, no problem. We have ample of time. So next one.
So while we wait for him, which is going to be it was an introductory talk about terminologies, how to get terminologies right. It's my pleasure to introduce Dr. Farzad Paktel. who's going to connect his laptop, who's going to talk about what went wrong and how I fixed it.
You
And
cannot connect here. For example, you can connect over there. This is screen sharing mode.
I've been connecting all week. I've been connecting actually with the
That's not.
It is a wire.
With the wire that goes.
Have you got the wire here?
They don't understand. Just ask me. You want to connect it over on the dice?
Yeah.
Connect kar diya.
You know, we've been trying
Actually,
to tell
it's
people.
not allowed in the meeting to connect all them machines on the dice. Because if we will keep on doing, if you have 10 presenters, it may take 20 minutes. And everyone has different machine. So I cannot have the connectors and displays. So it's very difficult to share the screen. This is the third screen sharing mode that you are getting.
So thank you, Ganga, for a nice introduction. Hello, dear colleagues. Good afternoon. So we'll start the ophthalmic trauma session. Ganga asked me to show some slides, some cases, and talk about what went wrong. So I would like to have some voices from you and some comments from you. So my first case, 27-year-old lady, fracture 7 years ago, 4 times surgery to correct the telecanthus, but all failed. And look at the CT scan and let me know what's wrong here. What went wrong here? Any? Sorry. Okay. So, any other comments? So look at here. This is NOE fracture, nasoethmoidal fracture. Look at this particle here. This is NOE type 3. NOE type 3 needs to be fixed. We cannot leave it alone. We cannot fix it with just skin procedures, as the patient underwent like medial canthal tightening or skin actually surgeries. You need to fix that particle for transnasal wiring. Otherwise, you will fail your operation. And in the late phase of NOE, correction of telecanthus is really tough. It's very difficult. It's one of the nightmares. So what I did, made actually a wide osteotomy over the area, removed that bone particle from MCT. I found the MCT in between of many scars over there, put titanium plate here, fixed it to the bone, nasal bone, and that's it. So Ganga, let me know. I have put some patients here. Let me know just the time.
Yeah,
I can
so
move
so
on.
will be about 9 to 10 minutes per speaker, and then we'll have an interactive
Yeah,
discussion.
you just
yeah.
let me know.
Right.
So, a 35-year-old gentleman, I was asked to attend in the operation in our biggest hospital in Iran, and they told me, Professor, there is no globe here. What can we do for this patient? And look at here, we have just orbital cavity here, no midface, no forehead, no zygoma, nothing is there. The patient underwent a very bad car accident. He was like a lawyer. So what do you think? What do you do in such cases? No globe in the orbit after trauma. So,
He's
Good.
alive.
She's got something to say.
He is alive.
Yeah, I show you. He is too much.
Somebody has to pray for him.
Any comment here? Okay, good idea. Look at here. Tell me what's your idea. I immediately went to PACS and checked the CT scan of the patient. Look at here.
The next time you join us as faculty, okay?
So you may see we have no zygoma bone here, no orbit anymore. Where is the globe? Can you see the globe? Anybody? Okay. Could you recognize the globe? Okay. What's the globe? Here is the globe. This is the globe filled with actually blood. And what I did was to reconstruct the orbit. It took like 8 hours for me to reconstruct the whole orbit. I made different kinds of techniques to because we had no bone there, we had just communicated fracture. I reconstructed the whole orbit, and it's just after 8 hours on table. So he's alive and he's talking. He went back to work. Unfortunately, he cannot see anymore. So, 33-year-old man. Actually, he was admitted to our main hospital in Iran, and two of our oculoplastic colleagues started methylprednisolone 1 gram per day for 5 days because the patient had like FC vision and positive RAPD. What's wrong here? Any comments? So it's a typical case. In this situation, the patient actually fell down when he was walking or bicycling or something, and he cannot remember what happened. He just remember, I lost my vision. So any such situation, you should consider.
Anybody see a radiological sign there?
Oh yeah, it's really important for all ophthalmologists. You should be
Yeah, go
familiar
ahead.
with this sign.
Okay.
Oh.
There's a nice radiological sign spanning between the orbit and the sinus. Am I giving it away?
That's the thing that all my colleagues, even faculty members, professors in the university was misled. It's
Right.
not air. No, it's not air. Air is, it's uniform. It takes the form of the surrounding tissues. It cannot be like irregular shape or like that. So look at here. It's a typical pattern for wooden foreign bodies. And just imagine the patient received methylprednisolone for 5 days without any improvement, but he started to show some discharge from nobody knows from where. So at the last moment, they asked for my consult. Immediately, I knew that what's happening for this patient, went to OR and took out that foreign body from inside the ethmoid sinus, just abating the optic nerve, compressing the optic nerve, remove it. And actually the patient was very lucky not to develop any kind of infection after that things. The patient is now 20 on 20 with full extraocular movements. Ganga, just let me know.
Yeah, sure.
Very interesting case. Ganga knows that this is my key message in the last 2 years for medial canthal foreign body. So this case went to our emergency department. Our senior, actually faculty assumed, okay, it's like a glass in the medial part of the eye. Let's just remove it in the OR. Just in the OR, they assume it's stuck there. Called me, Professor, can I have a look? And it's stuck. We cannot bring it out. So look at here. Oh, this is the examination, 2020 lid laceration, something. Look at here. This is a glass in the middle part. The patient is 20/20, no other complaint, just a foreign body over there, and it's stuck over there. What do you do? What do you do for the patient? What's wrong here?
I just take trauma sessions. People are okay.
Take it close. Okay, that's the thing that they wanted to do. This is just before prep and rep. What is this water here? Yeah, it's CSF. It's CSF. So I remember my resident, my fellow, my others were just playing with that thing to remove it with just gloves. I just took their risk. Do not touch anything. Okay, look at this foreign body here, just passing through the floor, to the roof, to the brain. And after angiography, I found that, I'm not sure if I put angio here, it was just abutting, just touching ACA in the brain. Just imagine what could happen if just 1 millimeter further the patient would die. So we explored, we approached through transcranial craniotomy, opened the whole area, protected ACA, put some mesh there, and this is the entrance of the foreign body. After making sure everything is safe from the brain, I just smoothly pull it out. So the message is, do not play with any medial canthal foreign bodies unless you're sure it's just small one. Do not touch it. Do not play with that. Oh yeah, this is the angiography. we were lucky that the patient is still alive. I'm seeing that patient. He was very lucky. Okay. I do not want to lecture for you. Ganga told me I need to just show cases, not lecture. Okay, let's go further. So I sorted my slides from smaller to more difficult cases. This is in between. It's a usual scenario. This baby, actually this kid, 8-year-old boy, very naughty, played in the playground. Then after coming home, he just fainted. They actually took the baby to hospitals, MRI, 48 hours under observation by neurosurgeons. Nothing was found for this patient. What do you think? What's wrong here? No. Exactly. Oculocardial reflex. Oculocardial reflex. Yeah, the patient fainted because of the severe bradycardia. And what's wrong? This is teardrop sign. Yeah. The inferior rectus muscle is incarcerated in the fracture over there. So this is another unusual but very important thing. No ophthalmologist should miss it. Nobody should miss it. So Ganga just let me know.
Okay,
I
we can
may
finish
try-
this case and we'll just.
Yeah, after surgery, reconstructing the orbit, repositioning the medial rectus muscle, everything is fine. And this is the question you asked. I think the first day you asked if we could go for delayed repair of fracture or not. This is my answer again to you. Yes, we can go, but we may have some actually suboptimal results. There is a very good study showing that if you go for delayed surgery, you will have severe restriction for 2% of patients, and persistent diplopia may happen with 24% with muscular entrapment and 46 among those with the septal entrapment. This is in opposite that the general belief is. So Ganga, just let me
Yeah, I think time's up. Yeah, that's
Okay.
right. So what are the few take-home points you'd give us? And later on we'll have discussion. Yeah. What are the few take-home points you'll tell us?
Sorry.
What are the few take-home points you have for the audience?
I think they took all messages.
Right.
That's great. Yeah.
Yeah. So the important thing is radiological science. Don't be the ophthalmologist who reads the reports. Everything that's black on a CT scan is not air. So how will you differentiate on a scan? Along an oculoplastic surgeon there in back. Air versus foreign body. How can you know that ahead of time? Anybody? Anybody? Volunteer? Sorry? So that's where you have the concept of Hounsfield units. So all on your computer systems, if you're using your software to look at the scans, the digital data, you can actually measure the density of that black and white. For example, metal will also look white, bone will also look white, but you put your Hounsfield units, it's a little marker that you put on the opacity, that will give you the amount of Hounsfield units, and that will tell you whether it's bone or metal. It's white. Likewise, black is wood or air. You will know whether it's wood or air based on the Hounsfield units. For example, air is a minus 1000. Okay, but wood will be about 500. But they will both appear black on the scan. So that's an important point I would take. Thank you very much, Farzad.
Any questions? Thank you. Yeah.
How long can wait after muscular entrapment?
It's a great question actually, but I try to answer you. You know, we have the philosophy you can go for repair of fractures from 3 months. Then some studies show that 3 months is too late. You will end up with some restrictive myopathy then. So some cohort studies showed up to 6 weeks is okay. Then some colleagues were more actually maybe wanted to make it like 3 weeks, but it seems that up to 6 weeks is okay for general, not all fractures, but 3 weeks is the best time.
Okay, so we'll move on. I would like to introduce my friend Mohammed Al Tawfiq, who is going to talk about terminologies in ocular trauma. So, Dr. Tawfiq.
We will just step back forward for what I'm calling about ocular terminology. This is what you need to know. Ophthalmologists are unable to communicate with each other of terms they will use to describe an eye injury are not standardized. What's our common problem? The common problem is to use of a different term to describe the same energy. We can call double penetrating, double perforating, and perforating. What's meaning of both? Use the word of blunt without specifying whether it's referred to an agent or this an result of the injury. This is a two different way. Alternatively, use even within the same publication two different terms, penetrating, perforating, to describing the same injury. This is a common problem. Use the term of penetrating to describe any open globe injury. You see, the globe is open, you could have a penetrating trauma. It's not right. Use the term of rupture to describe any open globe injury. It is not right. Lack of indicating of tissue. So Birmingham eye trauma terminology, BETT, the key to this system is that all definitions referring to the entire globe, not to the specific tissues. There is no need to therefore to include the reference at the tissue in the term. If a tissue is specified, it refers to a location. It's not modifier for the term. So let's take a tour for this Birmingham eye trauma terminology. Eye wall, it's related to sclera and cornea. Closed globe injury means no full thickness wound of the eye wall. Meaning of open globe injury, it's meaning of full thickness wound of the eye wall. If you have a contusion, that's meaning no wound of the eye wall. So first we know the eye wall. Lamellar laceration, it's meaning partial thickness wound of the eye wall. Rupture, meaning full thickness wound of the eye wall caused by a large blunt object. So we need full thickness, we need type of object, blunt object. Laceration, full thickness wound of the eye wall caused by the sharp object. So those are the two different terminology. Penetrating injury and entrance wound is present. When you describe a case of intraocular foreign body, it's not a case of rupture. It's a case of intraocular foreign body. When you describe to your friend, if your colleague, I have a case of rupture, where is the intraocular foreign body is present? It's a case of intraocular foreign body. Perforating injury, that's meaning you have an inlet and exit wound. So this is a type of closed globe injury. This is a type of open globe injury. This is a type of contusion, not globe. The globe is intact, the wall is intact. Lamellar laceration, non full thickness. Rupture, it's meaning full thickness with a blunt object, like all of these types. Laceration, it's full thickness wound with a sharp object. Penetrating, we have an inlet without exit. Intraocular foreign body, you have definite intraocular foreign bodies if the case is intraocular foreign body. Perforating, you have inlet and you have exit. So the case is a perforating intraocular injury. So let's summarize in just 2 slides. If you have injury, we can classify it as a closed injury loop. We call lamellar laceration or we call contusion. So if you don't have a wound, full thickness wound, you can describe it as a lamellar laceration or contusion. Lamellar laceration, you have a partial thickness wound. Contusion, you don't have a wound. If you describe it as the open globe injury, you have a globe is open. So if it's ruptured, if the globe is ruptured or opened by a blunt object, laceration, you have full thickness wound, perforating, intraocular foreign body, penetrating trauma. So if you have just inlet, it's perforating. If you have just inlet and exit, it's penetrating and intraocular foreign body. If you describe it by the type of object, so if you have a patient and you take a history from the patient, I have an injury with a knife, this is a sharp object. If I have a patient, I just tennis ball is just hit my eye, this is a blunt object. So if you describe it by a blunt object, so we have a dead eyeball is open full thickness, so it's meaning if eyeball is open full thickness by a blunt object, that's meaning blunt, it's sharp, it's a rupture globe. If the globe is open, not open, this means contusion. So if you have an eyeball hit the globe with no open globe, and we have a vitreous hemorrhage, we have a choroidal detachment, we have a hyphema, we describe this trauma as a contusion. Okay, If we describe by history, take the history from the patient that is hitting by the sharp object and the eyeball open partial thickness, that means we have a case of lamellar laceration. If you have a case with eye open full thickness and in partial thickness, it's called partial thickness laceration or lamellar laceration. If the globe is open, did the object leave the eyeball or not? If the object is not leaving the eyeball, it's called intraocular foreign body. So the object is inside the eyeball. It's an intraocular foreign body case. If it's yes, leaving the eyeball through the same wound, it's no or yes. No, it's called imperforating. Yes, it's called penetrating. You just scan this slide and that's it. This is the conclusion of ocular trauma terminology. When you use it in communication, when you use it in publication, you need to follow this guidance, because when in our practice 90% or 99% of all of us, when you have a case of trauma, please, I have a case of ruptured globe. All of us tell this is a case of ruptured globe, and this is not true. I just take this few minutes because applying a PAT in your clinical practice as well as in your research, elect randomly is the term to describe the eye energy. Don't elect randomly the term to describe the eye injury. Using a standardized language in ocular terminology is a mandatory to avoid ambiguity between healthcare professionals and regarding of the type of communication. We are in Africa and we are in Arab world, we are in Asia and we are in Far East, we are in Far West. So we have the same language to communicate what's the type of ocular trauma. And thank you.
Thank you very much, Dr. Tawfiq. It's like speak good English campaign. You speak the right terminology. So on the telephone, you call your mentor, preceptor, your fellowship director, or even your consultant in charge. When you say a word, the consultant on the other end of the phone should know exactly what happened. And I think that's what it's all about. And I think even senior ophthalmologists are guilty of using the wrong terminologies, right? And so instead of speaking bad words, let's start speaking good words from one. Thank you very much for reminding us. My pleasure now to introduce Dr. Yasser Khan. Do you want to connect your laptop? Going to talk about an interesting adnexal problem of missed lacrimal drainage system injuries and how to identify them and how to manage them, and how difficult it is to manage
I go
them.
camping. I wish I was. I do a lot of camping, but anyways, so yeah, so basically, thank you. So you know, when it comes to lacrimal trauma, so I see, I mean, in all these years of practice, I see a lot of I've seen a lot of eyelid and canalicular trauma. I actually have not seen a lot of lacrimal system, nasolacrimal duct trauma. And so basically, I mean, I think when it comes to the nasolacrimal duct, because I separate it, this talk is not about canalicular trauma. That's a different eyelid anatomy, whatever talk. This talk is about the NLD itself, the nasolacrimal duct. So there's two ways it can get damaged, either through trauma or surgical, and the most common being decompression. Okay, so I'll talk about those two. In my opinion, when you have dacry trauma, it's never a good thing. It's never a good sign. I mean, bad things cause a nasolacrimal duct trauma, in my opinion. Either it's a nasal fracture, a bad medial wall fracture, an injury like this, or the really bad stuff that Farzad showed. It's just never a good thing. You get, NOE fractures, a Lefort 2, 3, especially 3, can cause lacrimal duct trauma, and so it's not good. Okay, so when you see a patient like this, you go, oh my God, what the heck do I do? Like your residents or your colleagues did, right? What do I do with this? This is a mess. Everything's falling apart. There's potentially no eyeball. What do you do? And the talk's almost over. The answer is you do nothing. Okay, for now. Okay, as an ophthalmologist or as an oculoplastic surgeon, you do nothing for now, unless it's a scenario where there's where there's a globe injury. So you got to make sure the eye's okay. So do an ocular exam, even in Emerge, because don't trust the emergency doctors. I don't know where we're all from different places. Where I come from, I don't trust the emergency doctors, frankly speaking. So make sure the eye's okay. Examine the eyelid for canalicular or eyelid injury, but even then you wouldn't do anything to the eyelids or the canalicular. Why? Because ABCs, airway, breathing, circulation is most important. Make sure that they're alive and they'll survive. Get a CAT scan ordered. Make sure that there's nothing in the brain, and there's no CSF leak. There's nothing really bad going on. and let the plastics guys and the OMF guys do whatever they need to do if it's a major facial fracture. Because there are maybe a few oculoplastic surgeons that may do major facial trauma. I think most of us don't. We do kind of periorbital fractures, zygoma, things like that. Okay, and eventually, if you do everything right, in the end, we come in when they look like this. Okay, when they've been fixed, and basically you have this, and when they look like this, that's when we come in, and that's when we do a complete nasolacrimal duct oculoplastics assessment. We check the lid position, make sure there's no ectropion, it's nicely opposed. You check the punctum, make sure the punctum's working. You make sure the lacrimal pump function's working. Sometimes with major trauma, they get facial palsy. Okay, so the lacrimal pump, when you blink, that sucks the tears into the lacrimal system. You got to make sure that pump is working, and ectropion, and then you do a sinus exam. If you're someone that's comfortable, you can even just look with a light. If you don't have a nasal speculum, you can look with a light. Or if you don't have I've got a 30 angle or 0 angled rigid endoscope that I use to look up the nasal passages. But if you don't have that, get your ENT colleague to look and make sure that inside the nose they're okay. So do a sinus exam. And if they have dacryocystitis, you treat it first. You still don't do anything. You treat that first with antibiotics. I give like a cephalosporin, second generation, third generation, depending on how bad it is. You treat that first, let them quiet down. Then you go say, then you still don't do anything. You do one thing, you do lacrimal irrigation, and to see where they are, whether they're obstructed or not. Then you can do something. And usually the thing to do if they're blocked is a DCR. And I'll quickly get into it briefly, whether to do external or endo. I just do endonasal DCRs unless there's some kind of contraindication to it. I do my what I call a non-endoscopic endonasal DCR. I've also in the past gotten lacrimal duct issues with decompression. Okay, the NLD is not rare. You have to know about it, prevent it, and treat it. You may see these patients because stuff does happen. You may see these patients in your clinic after they've had a decompression. But I must admit that going from this is not what I want. I don't want to fix this and have them tearing like that. Okay, so you want to avoid that scenario. And so what is the risk of NLD injury? Dr. Seif and Norman Shore looked at this a little while ago, a long time ago, and they found that 84 eyes that had transantral ethmoidectomy had an nasolacrimal duct obstruction. And they basically even with fracture repair, they found that can happen. So ever since I switched a long time ago to do a transcaruncle approach, I basically had 0 incidence of nasolacrimal duct trauma. I used to have it when I used to make my skin excision, like this, for example. When I first started practice, but then when I went transcaruncle, when I do my surgery, I go posterior to the posterior lacrimal crest, and I avoid any kind of injury. And to be honest, from external, there's studies that have looked at external orbital decompression, and the rates have been high, but not with transcaruncle. And this is this is a bit of old data. So far I've still been good, although I warn every patient that there's a risk of nasolacrimal duct obstruction. This is just for those who have not seen transcaruncle before. This is just how I do my transcaruncle. It's another small incision procedure, which I like, and it's usually about a 15-20 minute procedure, so it's less traumatic to the patient. They wake up happy with less swelling, and the job is done. And you minimize the complications. Complications are never 0, but you minimize the complications. I do not use an endoscope, but I put one in just to give myself a view. I do this with loops, okay? And you can see it's a very small incision. You do the decompression and you're finished. So transcaruncal decompression is a safe bet to avoid lacrimal injury. Good. And so what you, in general, need is obviously what I always say is know your anatomy, have good instrumentation, good imaging, and a proper OR, and have some guts. I did have this procedure, but I think, how much time do we have, Ganga? Do we have time?
Yeah, about 3 minutes.
Okay, so this is how I do my DCRs, okay? It's a very simple setup. I don't have an endoscope. I don't do them externally. I do them endonasally without the endoscope, and I've been doing them for the last 15 years, I think, at least. And again, very simple, inexpensive setup that can be done anywhere. And I'll show you a video, and I'll end with that. That should be enough time. Now, I obviously use an endoscope to film this. It was a Mongolian fellow I had many who kind of filmed this, but I do it with my loops and with direct visualization. Okay, I put an endo illuminator in the lower punctum that illuminates the inside of the nasal passage. Now what I do is I just go straight in with my kerosene rongeur and just grab whatever I can, basically. And so what I'm grabbing is I'm grabbing the nasal mucosa, the thin lacrimal bone, and the anterior flap. Okay, all in one. So that increases the efficiency of the surgery. I use a long kerosene rongeur, and this is me doing my ostomy, and that's exactly what my view is like. Okay. That's the endo illuminator that illuminates everything. You can actually see everything with direct visualization, and you know exactly where to do your surgery because the light guides you. Just follow the light. Be like that. Was it mosquitoes or flies that go by the light bulb? Both. Flies. Mosquitoes. That's fine. Moths. That's right, moth. Thank you. Okay, follow them. Okay, see, it's follow the light, and you can see it's getting brighter and brighter as the bone is gone, and you see the lacrimal sac here. And I do take a crescent knife and just cut the lacrimal sac, and I cut both my anterior and posterior flaps. So I don't suture flaps, at least not for my endonasal. So you take the anterior and posterior flaps, start using a pituitary forceps, another inexpensive instrument. That's the endo illuminator. So I'm through. I kind of do a look around, make sure that the ostomy is to the size that I want. I always check to make sure that I'm open. And you can see irrigation is free, the water is coming out. 30 seconds, Aganga. And then I basically intubate the system. And so, I mean, just because, to stay on topic, all nasolacrimal duct trauma that I've seen, whether it's surgical or traumatic, I will repair in this method, unless there's something else that I need to know about or unusual with the nasal passage. I stent out, and the other thing very, very important is, especially in traumatic cases, is stent them all. I keep the stent in from 3 to 6 months. Usually it's 6 weeks if it's a standard DCR patient. Almost done.
Okay.
Usually it's 6 weeks if it's a standard DCR patient, but if it's traumatic or recurrent or post-surgical, then I keep it for 3 to 6 months. Okay, great. Thank you very much, guys.
Thank you, Yasin. Before Professor Amirawan introduces the next speaker, the purpose of this particular topic was that about 5 to 15% of all orbitofacial fractures have nasolacrimal duct involvement. And yes, majority of them may not be symptomatic, but they come back late with a lot of hardware repaired by the craniomaxillofacial surgeons with plates and screws. And then going and doing a DCR, external endoscopic, is a nightmare. So be the ophthalmologists and the oculoplastic surgeons critically evaluate the lacrimal drainage system and at least be aware that there's an obstruction. If you can, I tend to prophylactically intubate these systems so they can avoid a DCR later. But if you're going to be doing a DCR later with plates and screws, sometimes endoscopic DCR is not as successful or as easy or bleeds a lot, or sometimes you may have to remove a lot of hardware in that area before you do a DCR. So that's an important take-home message.
So I would like to introduce my friend.
Assalamu alaikum. Good evening, all. And I think this is the last presentation for me in this conference. It was amazing. But at the end of this, I have a fever. That's why I will be very fast. So challenging pediatric globe injury, I pray and thanks God I'm not working with the pediatric. I don't like to work in pediatric. I don't like to repair anything in the pediatric. I know the information only. Very good that we are having a colleague called oculoplastic. Just throw this case to them and forget what you are doing, and they will solve the problem. Uh, so open globe injury, there is either rupture or laceration, and laceration can be either penetrating or perforating. Open globe injury, eye trauma is the leading cause of monocular blindness worldwide. Open globe injury refers to all thickness injury to the cornea and or sclera. There is two types, as we mentioned earlier, as rupture. This mainly due to a blunt trauma, and there will be a full thickness defect at the weakest point in the wall, in the eye wall. Second most common of open globe injury. Laceration, as we mentioned, there is a penetrating, only one wound. The most common form of open globe injury, this one is penetrating. Perforating, there will be a two opening in the globe. So there will be an entrance and exit. That means the foreign body come from one side and exit from the other side. And this is a very problematic, and difficult cases. Intraocular foreign bodies are also possible and need to a specific attention. There is a categorization of the type or zone of involvement. So if there is zone 1, zone 2, zone 3, there is many classification. Just I select this one actually from the online. There is a cornea and limbus, most common. There is an extended from the limbus to anterior 5 millimeter of sclera. So, and there is the one which is more difficult area posterior to the zone 2, i.e. deeper associated with worse prognosis. Causes of pediatric open globe injuries, they are a sharp object most commonly and are most frequent causes. And fireworks are also common worldwide. Abuse and or assault can be also in some societies. There is the most common place for globe injury in the pediatric, it is the house. So what are the possible complications? That's why we said there is a challenging in the pediatric management. There will be amblyopia, especially if this injury happened under the age of 5 years or 6, 7 years. Endophthalmitis, vitreous hemorrhage, and also corneal opacities, foreign body toxicity, sympathetic ophthalmia. It is rare, but it can happen. Autoimmune response leading to granulomatous inflammatory of both eyes. Factors that known to indicate poor visual acuity. This is very important. We have to take care about that. Younger age than 5 years. Any children below the age of 5 years, they carry a more high risk or indicate of poor visual acuity because there will be a result of amblyopia. Poor initial visual acuity, when we are examined and we can assess the visual acuity, and that at the time of examining of the patient, if there is an poor visual acuity, that means there will be a poor visual prognosis. And this is very important because you have to discuss all these factors with the family. Otherwise, after you finish, they will blame you. Why my son is not improving? And so many things that you can face. Posterior chamber involvement, that means we have moved to the posteriorly. It can be lead to many complications. So it can be retinal detachment, vitreous hemorrhage, involving especially the macula. It will lead also to more poor visual prognosis. So long with length, the long of the wound, if the length is a small one, that means the area, especially if we talk about the cornea, eccentric, very small one, just use suture and there will be no problem in the visual axis. But if this one in the center and running from the center to the limbal area, we will have astigmatism, we will have another problem, may associated also with cataract, and you have to remove, then you have a difficulty to insert the lens. And if you insert the lens, there will be, I know there is a debate about inserting the lenses in the first time, but if you insert the lens, there will be another problem of inflammation. So it's a dilemma of dealing with the pediatric or children having a ruptured globe. Retinal detachment, as I mentioned, and endophthalmitis. So this is very important. If we come just out from our lecture, this is the most important we need to highlight. And as I tell you in the beginning, you don't need to play with the eye. If you know, you do. If you don't, refer please to another person. For me, just when I'm hearing about this one, okay, how old? Like this, okay. Let us see who is the oculoplastic available and we refer the patient. Yes, we have to think like this is your child. You have to give him the best chance, best hand of management, I think. Open globe injury can be evaluated by history meter, examination, imaging. As you know, there will be ultrasound, but we have to take care about, don't do a pressure on that. CT scan, but we have also, and as you know all, MRI is contraindicated if we are thinking there is a metals inside the eye. This is just, I select a few, some of the abstract that have mentioned from early 70s until now. And most of them, you will find them, they are agreed on a certain point. So this one, open globe injury in children, factor predictive of poor visual acuity. So this is the aim of that one. This is, cannot see, but this published in 7 March 2008, 20 patients less than 16 years as an average in Manchester Royal Eye Hospital, UK. The conclusion, factor suggesting unfavorable final visual acuity after open globe injury in children are, as you mentioned, we are repeating young, poor initial visual acuity, presence of relative apparent pupillary defect, maybe we didn't mention that earlier, absence of the red reflex, and also if there is a cataract, as we mentioned, and types and number of surgeries performed till we reach to the last point. This another one is in the journal Francis of Ophthalmology. I think this was done in Tunisia. Also, there is they are checking for epidemiology and prognostic factor of open globe injury. This abstract published in September in Elsewhere conducted in Tunisia. They are this one. I think they are mentioned in that journal in the volume 43. These the conclusions. They are saying that open globe injury in children occur most frequently in school age boys. So most, as we said, below the age of 6 or 7 years. I don't know, but this is their report. But most of the abstract they are indicating less than 5 years in home rather than school. Prognosis is determined by presenting visual acuity and trauma score, as we mentioned, and wound severity and location. This another journal of Americans, they have this open globe injury in children, and this happened abstract is 70 patients were reviewed, published in Journal of American Association for Pediatric Ophthalmology and Strabismus in 1998. So more than 24 years from now. And they are concluding that the prognosis after an open globe injury in children is strongly influenced by the nature of the injury, the extent of the initial damage, as we say, the longest of the wound. Visual outcome is better in eyes that require only primary repair. So if you are going more than one surgery, then we are anticipating to have a poor prognosis in visual acuity. This is another one, open globe injury in children, a retrospective analysis. This one is abstracts of 180 eyes were reviewed in 1973 and between 1973 and 1993. You can see it's almost 20 years. This published in March 2001. They are just collecting from that date till they publish it in 2001 in Journal of Pediatric Ophthalmology and Strabismus again. They conclude also from this abstract that the nature of the injury and the patient age are the main determining factor in the outcome of the open globe injury in children. As you see, we are all the times talking about the same result. You can see now this one is 19, they start 1973 up to 19. So, and then another one we have it in 1998, another one 2008. So most of them, they are having the same almost result. This another one, abstract of 46 patients, 2005-2015, published in 8 November 2021, conducted by University Hospital in Thailand, and they are concluding that open globe injury occurs mostly in male children under 10 years of age during playing at home. This is why I mentioned in the earlier, most of the time. Maybe now anyone can say now the life is changed. Most of the time our children, starting from 2 years now, we are pushing them to the school, so they are exposed to the injury. So they are also public awareness about, they ask about public awareness about injury, its mechanism, and prevention measures should be raised in order to decrease the incidence of traumatic eye injury among the children. This is another one, which is also characteristic and visual prognosis, abstract retrospective of 1064, 2007, 2018, Shanghai, China. And the conclusion found that boys and preschool children were particularly vulnerable to open globe injury than others. Penetrating injury were the most common injury type that detecting the final visual acuity related to either if there is a hypemia, we have mentioned this, vitreous hemorrhage, endophthalmitis, and others. Within 1 minute, I think this is a take-home message. Open globe injury in children is a challenging in surgical intervention and outcome. Early management and education the family is the key factor for better prognosis. We can avoid many complications by proper follow-up and proper time interfering. Thank you very much.
Thank you very much, Dr. Lamri. Very nice talk. I think pediatric cases, globe rupture, you have to be careful because the kids are not going to tell much. So usually they have delay in presentation. So I remember one case like 5-6 days later, globe rupture, corneal laceration. I sutured it up, even removed some iris, abscised the tissue as well. Still developed endophthalmitis. Then I did vitrectomy. Eventually, he had a very good outcome. Vision is 6/9. But you have to be careful and you have to monitor later the patients as well. Thank you. Yes.
A quick comment.
Yeah.
Thank you, Dr. Amri. Great presentation. So I would like to make a comment about sometimes trauma in children is different than in adults. So I may make you some examples. I'm seeing patients, children that have, they are playing with batteries, like alkaline batteries in the toys, and I remember a few cases that they put the battery inside the furnaces, and after 24 hours the baby was taken to the emergency room, and my residence fellows didn't find anything. Next day the whole globe was necrosed. So be careful about unusual presentations. I've seen babies after walking and playing in the yard, they come back with just a little bit of the redness. They bring to the emergency room, does the redness, nothing, and then come back with endophthalmitis. Sometimes, Dr. Amri knows better than me, sometimes like a pin goes inside the globe and comes out without anything obvious, just a bit. So we need to be very careful, and for any case that you're suspicious something has happened, I always say, do not hesitate to take the patient to OR and make a very good comprehensive exam under anesthesia. And you're totally right, Dr. Anamri. The nature of the injury is the most important one. It goes with glass injuries like bullets, like stab wounds, totally different to like a simple laceration.
Thank you for your comment. So I would like to introduce my friend Gangadhar Sundar, who is going to present about practical classification of orbital and orbital facial fractures. Dr. Sundar.
Yeah, thank you, Professor Rahman. Just a quick message about pediatric injuries. Somebody told me that pediatric medicine is like veterinary medicine. They cannot talk to you. And the other piece of history is that children never tell you the true story of having been in a fight at school, because if they say I fought with my friends, you get one more injury from the parents. So be careful about the history that children give you, and Farzad's point about anything not right, keep a low threshold for a proper examination. I'm going to go to my talk. I'm going to talk a little bit about ocular plastics, which is what I do. Something called a practical classification of orbital and orbitofacial fractures. So you realize that I'm not just talking about orbital, but we're talking orbitofacial, because the orbit is the most important part of the midfacial orbital facial skeleton. And it's very commonly involved, but oftentimes the rest of the face is involved that is oftentimes ignored by us ophthalmologists. So I work in a multidisciplinary hospital, a university hospital, where I work in close collaboration with my craniomaxillofacial surgeons, my neurosurgeons, my rhinologists, which helps me with my thyroid eye disease, dacryology, oncological practice, and also with trauma. So those of you young aspiring oculoplastic surgeons, learn to work in multidisciplinary units, and that's a message I would say, go across the street so that you can actually work with your craniomaxillofacial surgeons, so you recognize a lot of these fractures. And the conflicts of interest, I do have a book on orbital and orbitofacial fractures, but I have no financial gains here. So the traditional role of an ophthalmologist has been addressed before, is to assess the concept of open and closed globe injuries. Once there's no globe injuries, we wash our hands off the patients as well. And traditionally, again, when CT scan, when you suspect a fracture, we were doing CT scan of the orbits and stopping right there. And several fractures of the other parts of the facial skeleton have been missed when the patient comes to you with a periorbital injury and you've not done a CT scan of the entire facial skeleton. And that's where you have to go beyond being an ophthalmologist to becoming an oculoplastic, and it's not the traditional mid-facial oculoplastic, but an oculofacial surgeon. In fact, the American Society of Oculoplastic Surgery is now labeled as Oculofacial Surgery Society. So think of the whole face. So I'm going to talk about a fracture classification and specific modifiers that kind of tells you when to intervene, how to intervene, who should intervene, and how should you intervene for these patients. And that I put the mnemonic A, B, C, D, E, F, G, H, which we have all learned in kindergarten itself. So what's a practical classification that we came with? This is exactly what is there already in the literature. We put it together for convenience so that we call them as simple or pure orbital fractures, which is the only aspect that is touched in our residency curriculum and taught to us, and most of us are managing. In other words, linear trapdoor fractures, as was shown before, or blowout fractures. What oftentimes we do not manage are the complex fractures, which also involve the orbit. And they are classified into ZMCs, zygomatic-maxillary complex fractures, which, by the way, is the second most common facial fracture next to the nasal bone fracture. So in fact, it's far more common than a blowout fracture. And if you're the oculoplastic surgeons who only manages blowout fractures, you're missing a whole bunch of other orbitofacial fractures. A rare is naso-orbitoethmoidal fractures that was shown by Dr. Farzad before. Then a classification called Lefort classification or orbitofacial fractures, where partially either the medial wall and the floor alone or the medial wall and the lateral wall is affected, so that the entire orbit gets disconnected from the craniofacial skeleton. And of course, cranio-orbitofacial fractures, which are skull-based injuries, where we saw cases of CSF leaks, which again is oftentimes not recognized. And finally, there's a whole group of patients who are panfacial fractures. So if you look at if you look at pure blowout fractures, internal fractures is what the textbooks talk about. It's either one wall or two walls. You can actually, most oftentimes the floor or isolated medial wall, but sometimes can be the medial wall and the floor. And the combined medial wall floor again is badly managed by us oculoplastic surgeons. The rest of the facial skeleton is intact. There's no role for a craniomaxillofacial surgeon fixing these. We should take charge of these and go ahead and do this without their help. So the role of ophthalmologist is in diagnosis, not just reading the report of the CT scan, but reading the CT scan yourself. Make your decision whether I'm going to intervene or not. The younger the patient, the earlier I intervene. The children, I go in ASAP. And finally, you're responsible for the management, outcomes, and managing the complications. And once again, keeping the principles in mind, life comes first. The globe is important, keeping the vision in mind, and then only then you do an orbital reconstruction. Whereas you come to the rest of the complex or the orbitofacial fractures, these are also called external fractures, where it's not just the walls alone involved, but the rims are also involved. So in other words, the rims have to be reduced and fixated rather than fixing. And I have seen enough patients who referred to me where the oculoplastic surgeon has gone inside the orbit, put implants inside without getting the rest of the orbitofacial skeleton and the rims put in place. So that's where you have to work with your craniomaxillofacial surgeons, whether it's a neurosurgeon, craniomaxillofacial surgeon, ENT surgeon, it doesn't really matter. And we play a role not only in assessing the globe and the orbits, but go along as a team member and sequencing these fractures and going and fixing it as well. And the same principles really apply, but once the rest of the face is involved, aesthetics also kind of comes in. So are all orbital fractures blowout fractures? You can see that's the entire spectrum of orbitofacial fractures, and this kind of shows blowout fractures is only 30%. In other words, 70% of them are orbitofacial fractures, where I strongly believe that we should be involved. Examples of pure single wall blowout fractures of the floor, or a combined floor medial wall fractures. And what we don't address is in the concept of the orbital strut, which is the inframedial angle, which oftentimes is poorly reconstructed. So a quick anatomical learning points. Number one, just as how you have an external facial buttresses, which is support systems for the entire local skeleton, you have an internal buttress, which is the junction of the floor and the medial wall. If you don't reconstruct that right, if you put any implant inside the orbit, still the globe is not well supported. So we define the concept of the angle of the inframedial orbital strut, which is the angle between the floor and the medial wall, which you can measure on the contralateral side, and you can replicate reconstruction when you do the deformed orbit. The second most important thing you see on the right side is the concept of the posterior ledge, and that defines the posterior extent of the floor fracture. And if you are the oculoplastic surgeon who does not dissect the orbital contents all the way to the back of the maxillary sinus and reduce it in the contents and put your plate on that posterior ledge, oftentimes we are poorly repairing these fractures, and I can show here. So here's an example of a good replication of anatomical reconstruction compared to the orbit on the other side based on the angle of inframedial orbital strut by pre-bending these implants. So these are examples of patients where we now use bioresorbable implants. If you look at the scan on the right, it seems like there's no fracture at all. It's the same fracture that you see on this side. The floor medial wall fracture has been fixed with the bioresorbable implant. Implant is absorbed, the bone is reformed, and the patient back to normal without any long-term complications. Here's an example of a patient where the anatomical guidelines were not followed. An implant was placed. You can see the implant is not placed on the posterior ledge, but well above the posterior ledge, causing complications, or the implant is too low, again forgetting the surgical or applied anatomy of the orbitofacial skeleton. Yet another patient's, more you can see, implants inadequate reconstruction with the silicone block, vast majority of the floor and the inferior rectus has not been reduced, or inappropriately placed implants in the sinus itself. So here are examples of complex facial fractures where we are talking about NOEs, Dr. Farzad talked about it, or you can see on the frame right, everything from top, including the skull base, the brain, CSF, dura is affected, orbit, all four walls are affected. So that's a cranio-orbitofacial fracture, which by default you should be managing along with the neurosurgeon. Examples of ZMC fractures, which there are different types, type 1, 2, and 3, whether it's a single piece, multiple pieces, these articulate with the orbit in 3 or 4 different locations. And one of the landmarks of reconstructing is making sure there's good alignment both along the inferior rim, the frontozygomatic suture, and also the zygomatic sphenoid suture deep inside itself. Here's an example of a patient where you don't know where to start and where to finish. You can see everything from the superolateral wall, the lateral wall completely displaced, large soft tissue laceration. The globe thankfully is intact. And I always say fractures are good because nature's decompression of the orbit, you don't develop much of a compartment syndrome where you have anatomical sequential correction. Roof followed by the lateral wall, followed by the inferior wall, and then the internal orbital walls. You can get anatomical correction so you can get very good reconstruction. So, how about NOE fractures? These account for 3 to 5% of all orbitofacial fractures. The significance for us is number one, telecanthus. Dr. Farzad talked about it. The second important part is that a good proportion of them have lacrimal drainage systems. So as you can see over here, these are patients where if you prophylactically intubate, you can avoid doing a DCR, because if you look at all the hardware in the bottom right, it's a nightmare doing a DCR in these patients. These patients bleed a lot with poor success rates and major complications. Another example of bad cranio-orbitofacial fractures. You can't wash your hands of this, saying that leave it to the neurosurgeon and maxillofacial surgeon. Once they manage the skull base and the CSF leaks are managed, you're responsible to making sure that the roof, lateral wall, inferior rim, internal walls are also reconstructed with these patients. Examples of preoperative and postoperative patients where you can get again anatomical good reconstruction, which in turn results in functional reconstruction and aesthetic rehabilitation. And finally, why should you do CT face and orbits? These are patients where if you only image the orbits, you'll miss the mandibular fracture. These are examples of panfacial fractures. So principles of management, open reduction with internal fixation. The reduction is very important. Oftentimes we are guilty of not completely reducing the orbital contents and just doing an internal fixation. So why should we ophthalmologists be involved? Because the craniomaxillofacial surgeons have limited anatomy of the orbital anatomy, leave alone the altered anatomy itself. They are not responsible for the vision. We are responsible for the vision of the patient as well. And we are responsible for the late complications that we see. So every time oculoplastic surgeon says, my craniomaxillofacial fixed it and he created the enophthalmos, it's actually our fault that we are not part of the team. We should earn our presence in a craniomaxillofacial surgeon who's fixing these orbitofacial fractures. So this classification is designed for us ophthalmologists and oculoplastic surgeons, goes beyond the traditional classification. Like Dr. Tawfiq talked about, speaking a common language, same terminology as well, so you can classify, define the threshold and timing information. So the last part I'm going to talk about is the patient-specific modifiers which we came up with. And we came up with the A, B, C, D, E, F, G. What does that really stand for? A stands for age. In other words, the younger the patient, including a child, the earlier you go in. The older the patient, you can actually sit on these patients like Dr. Yasser really talked about. The second, you want to know whether it's a bilateral or unilateral fractures, because the threshold for intervening one or both sides then comes into play. The complexity we talked about, complexity is basically orbitofacial fractures. You have to have a sequential approach to roof, lateral wall, rim, floor, and medial wall reconstruction. The degree of displacement is very minimally displaced. You can probably leave a lot of these fractures alone. The more displaced they are, you have a lower threshold to intervene in these patients as well. E stands for entrapment, and entrapment is a clinical sign, not a radiological sign. So whether the patient can move the globe or not, and if you're not sure whether the limitation of movement is from pain or entrapment, you can do a forced duction set. F stands for foreign bodies. So foreign bodies inside the globe or the orbit take precedence. G stands for globe injury. So that's where you or your resident has to be part of an assessment of a head and neck trauma victim. And finally, whether the patient is a high-risk patient or not. So as you can see, A to G, you can find out age determines the urgency and timing of intervention. B stands for the simple techniques versus complex techniques, larger incisions compared to simple smaller incisions. C stands for complex fractures, where you work as part of the team. There's a pure fracture, you work on your own and fix these orbits. D stands for degree of displacement. The less displaced, you can observe these fractures. E is entrapment. The more entrapped the tissues are, the younger the patient. You want to fix it as soon as possible, not wait until ischemia and fibrosis sets in. F, we talked about foreign body. These are patients you want to give antibiotics, imaging, localization, removal of the foreign body. G stands for globe. And anytime globe is involved, I'll stop in about a minute or so. Globe is involved, you tell the maxillofacial surgeon, do not touch this patient. Let's restore his vision first before you do an aggressive resection. And finally, the high-risk patients. We talked about a little bit about pediatric fractures. Beware this patient. He's got a vasovagal response every time he looks up. X-rays are often misleading. It's a clinical sign. You want to look it up as well. And again, be aware that soft tissue window imaging is not the same as bone window imaging. It's the same CT scan where on the top it doesn't seem like there's a fracture. It's only the bottom image that you see these crack fractures. And in young children, you can have trapdoor mechanisms which will require intervention. That's why don't read reports, don't read soft tissue images with bony skeleton. So I think I touched a lot of this. In the interest of time, I'll stop where we will talk about the various thresholds for intervention. Tawfiq talked about globe injuries. These are situations where, again, globe injuries are present, where the globe has to be fixed. In summary, I think just as how you have globe trauma terminology, orbital fracture trauma terminology is very important. Know the difference between orbital and orbitofacial fractures. Try to adopt the practical classification. Use patient-specific modifiers. And that's where the role of various national and supranational ophthalmic trauma societies come in, so that we can collaborate and we can do more for our patients. Thank you very much for your kind attention.
And other thing you have to keep in mind when you're looking, you need to see the scans. As Dr. Sundar was mentioning, just the reports, that's not enough. Similarly, come to ultrasound. So mostly what I do is, if I'm doing ocular ultrasound, I do myself to look for the pathology, because the kinetic part is important as well. So I don't rely just on the report or just on the photos, because a lot of things can be missed before you are going to dive into the eye, so you know the things better. So I would like to introduce Dr. Hakan, who is going to talk about ophthalmic trauma in Pakistan. Dr. Hakan, please.
Be a missionary and an evangelist.
I don't know I can speak right now or not. It's done with me in last 4 days. Rather than trauma, I will talk a non-conventional type of talk. Next, do we have a trauma? The answer is yes. Do we have a trauma surgeons? Do we have an organization that is working to train the ophthalmic trauma surgeon? The answer is no. Who will treat the trauma patient? Nobody knows. These are our questions that I am asking myself, my community, and a country with 200 million plus population. So I'm a little bitter, but what I can do, I have to speak what it is. I'm not going to talk this talk. You can listen any national or international meeting what it is. I mean, these are the statistics that everyone states for his country. But the purpose that me and Ganga organize this session is something different. I want to start a efforts like organization in Pakistan that should work for betterment of ophthalmic trauma surgery. The mission is whenever you starting, there are many behind you. When you start, very few. When you continue, no one is behind you. That's what happens usually. But the Ganga is successful. We joined him 7 years ago, and still we are following each other. Me and Ganga were the first founding members of this APOT society, and the society is doing good. The similar I want to do in Pakistan. I need few people to join me, so so we can have a proper trained ophthalmic trauma people. At least we could have a proper data. This data is from my institute. My fellow is sitting there. My resident is sitting there. They are doing trauma. Will you believe how much trauma I treat daily? I'm doing a public sector hospital that is surrounded by 30 million population. 30 million. And that means 3 million population. And daily, all the hospital is surrounded by big factories working with the metal, with the iron, chisel hammer injuries. So every day my residents are there. They are fed up from that trauma. Every day I have 10 retinal surgeries, 3 trauma. I have a 10 retinal surgery, 4 trauma. Intraocular foreign body is going in, out, whatever you say. I don't know what to do these. Where are those stats? And that's why I start collecting so I can convince someone. Then I start the public awareness campaign on national television. I started with the brochures. These are lying on the walls of my department. They are all there on my YouTube. Made the awareness videos, but nothing is coming out. The reason behind is one man cannot change the world. I need a team. Where I get team, where I should question it, I know, but Ganga knows how the things, the momentum. First momentum is very difficult. When it's a push, even 383 also moves without the push. So I need few people who can join me from Pakistan, from abroad, so we can start this ophthalmic trauma society. Pakistan Ophthalmic Trauma Society, POTS, or Trauma Society of Pakistan, shop, whatever you saw. So we have Yasser, so you can half join us, 50-50 Pakistanis, so you can join us. Ganga is there, Amar is there, my fellow is there, Manzar are there. So I mean, no logic of presenting this data unless you don't have a base of repairing and doing the surgery for these data. I have published dozens of papers on trauma. Then what? This is the only one institute. How many people you have trained for ophthalmic trauma? My residents get trained. When they get trained, they are not interested because there is no organization that can give them platform. No one is working without platform. Nobody can't for few. How many years? For 1 or 2 years, not for the whole life. And you know what's the return of this ophthalmic trauma? Mostly not good. They are severely traumatized eye. Barely you can salvage those eyes. Sometimes you can salvage, sometimes you don't. And even I know it's not about this country. Many countries, only the juniors operate the ocular trauma. Tawfiq is there, how? Egypt. The junior most is sent for the trauma surgery. No one is operating at the evening. Every trauma that is landing at the evening and night will be operating morning because you need a general anesthesia. And Egypt is same. I think I don't know how Iran behaves. Similar.
We have a very classified
Trauma society.
ocular trauma department. And I raise awareness of the trauma.
So do you have in every institute?
Yeah.
In every institute, you have ophthalmic trauma department.
We have in Toronto University special department for trauma, for ocular trauma. We have another division in 2 hospitals that's specified for very complex cases, as Ganga mentioned. I wanted to make some comments if we have time. I believe those complex cases is not general ophthalmology, not general orbital surgeon, not general maxillofacial surgeons. It needs a very specified team to be aware what to do with this kind of people. So we have these things in our
Okay,
three
you have
hospitals.
the ophthalmic trauma. Amri is working in UAE. Do you have trauma trained residents and trauma fellowship or
No.
any program?
No.
Yes, sir. Maybe the first world country. Yes, you have the trauma resident and trauma society and a trained trauma of the fellows.
No, I mean every specialty has their own kind of trauma. I mean, I deal with plastics and orbit. The
I mean,
retina guys deal with the retina
see,
trauma.
trauma is everywhere. In Canada, ice hockey gets a lot of trauma. Yes, so where it goes to the resident, and already bad eye is treated with the bad person. So who else we have here from Ganga? Ganga has.
Tawfiq.
Yes, that's the Tawfiq. I asked him. Tawfiq said yes, no. So so you see, it is all one first world, first round, middle and two, first world. So you see, even the first world in developed countries, it's rare. So it's a real need for develop. Why? They may not need much because they may have a specialized ocular trauma people. Those are working as a fellow or as a specialist. But we have lot of trauma. They don't have such trauma. People are educated. They have protective goggles while they are working. They have helmets. You see, in Egypt or in my country, maybe in UAE, yes, the laborers have their laws. They have goggles. In Egypt, who wears the goggles? Who wears the helmet? No one. Everyone is working. Yes. I mean, at least you have the law. Mhm.
And if there is only penetrating injury,
So-
they are calling us.
So very interestingly, you see the high ratio is knife somewhere. So domestic trauma is more. You see, it's not mean that it comes to me and then the glass, scissor, clippers, pen and pencil. Because in school nobody is teaching them that it's a dangerous thing to have a pen in your hand. You cannot throw it to your colleague. So the prevalence
In
of
fact,
that-
if I may intervene there, in the West, there are only two risk factors for trauma. One is a Y chromosome. You all know what I mean.
yes,
And alcohol.
yeah,
Thankfully, the second factor is not much of a factor here, right?
yeah.
And then second becomes a
The
knife
first
here.
factor play more role. You know?
Exactly, the Y chromosome.
And that you cannot get.
Whether you're in
Me
school
cannot
or
get.
college or university or a grown-up man, yeah. Sorry.
So these are the few things. Run the video if it's run. So when I am done, you just tell me. I'm not for the trauma this time.
So
for
3
here.
more minutes.
I've already presented. So trauma there for vitreoretinal surgery, something like that. So this is my fellow is doing. You see, a resident what they are doing. They read the book and do. Or sometimes somebody tells. So at least we should have a proper training, proper trauma course, awareness to the people. Awareness to the people is easy. I am doing, but how much? Not. So Ganga, let's do something. Ignite the spark here, please. Ignite the spark so these people may awake and make the Ophthalmic Trauma Society of Pakistan. At least make it for Lahore. Leave it for Pakistan. So I want to start from today. So let's join. How many of us here? I will be the front man. I will get all the punches. You wouldn't be affected. Ganga knows how much repercussions I will face and Amar knows. But I will be the front man. You wouldn't face. I will face
Nothing
the-
worthwhile in life comes easy.
Mean-
That's why I put a lot of pressure on Hussein and Amir
Yes,
to take this cause forward. And now
I am
Tawfiq
ready-
is
so I am
there,
ready,
Egypt.
Just spread the message more so we can convince together here that we need an ophthalmic trauma society as soon as possible, and we should need an ophthalmic trauma society course for fellows. We should run the workshops and courses for fellow. That's more important, and there should be a curriculum where less than fellows shouldn't go for operation for the surgery of trauma. So these three things, if we will achieve, curriculum, fellows, and trained fellows, its job is done.
Yeah, and I think dry workshop can be arranged, so that's not a problem.
Workshop.
So yeah, dry
But
ones. we
Ahmad,
don't
the
need-
issue is not the workshop can be a you, me, and sit at workshop. But until we don't have a platform, I said we need without platform, nothing is moving. You will get tired after a few times. I will get tired. Need a platform, need a projection, need an objective and mission. mission to achieve the mission and vision. That's the basic thing. So I hope.
Yes, sir.
I agree. I think having a local trauma society, I think is a good initial approach. But ocular trauma is also very diverse. I mean, for example, and that's why a team approach is good. I mean, in Canada, a resident cannot go to the operating room without staff being there. So we are there for. I mean, yeah, the resident may do the cases like globe rupture, but even like fracture repairs, the fellows may do it, but I have to be physically present. And that goes for every faculty.
I mean,
They
just,
can't do it by
believe
themselves.
me, I am also physically present, but I am somewhere subretinal space.
Yeah, well,
Physically
I'm
present.
physically
My fellow is present there, but the issue is unless he is not properly trained.
No,
So the issue is.
but my other point is that
Okay, I come to the end. I cannot speak. I am done with my road. So how many of us are joining for Ophthalmic Trauma Society of Pakistan? Just raise hand. How many? Farzad, you can be the member. No bar. No, where is the bar? I am just opening the floor. Both hands. You can join us volunteer. Just to spread the word of Ophthalmic trauma. Why not you? Why not?
Yeah.
also Hassan, yeah, I did.
Absolutely right.
No, but the other point I want to make is that ocular trauma is very diverse, right? So I mean, there's retina, there's plastics, so I mean, you're not going to do an orbital fracture repair, for example, right? Just like I'm not going to take an intraocular foreign body out. So I think like we need to approach that. So you just can't have one person
That's
doing
why
everything.
I asked Farzad and you first and Ganga. So I may need some 70% of your help. I remove minor things, you remove the bigger things. You see, Farzad showed orbit is missing. I said bye bye. So, yes,
Dr. Mansoor, yeah. Mansoor,
Yes,
yeah.
Manzar.
We got a conversation going. That's what it's all about.
UK is that we have regulatory body. For example, macular rod detachments have to be done within 24 hours. No ifs and buts.
So Manzar, we were talking for Pakistan.
No, definitely. What I'm
Yes.
saying that you need your
No.
hospital-based policy.
We don't have rules, we don't have curriculum, we don't have a society, we don't have a trained
But it
people.
doesn't mean things can't
That's
be done.
the 5 things that I wish to see when Ganga next year comes here. So help me, join me. Tawfiq is doing to Farzad, Amri. So I will make a group today of Ophthalmic Trauma Society, Pakistan. So maybe somebody will kill me after without question mark writing. So get my witness, 40 people are witness. So hopefully in next 3 months we will have something.
So this APOTs you heard about now is going to be POTS, Pakistan Ophthalmic Trauma Society. And December 10th, 2022 was the day the seed was planted under the ground. Right, Hussein? So with that, I thank Dr. Hussein and
You said what you said? Pots.
POTS.
Pots where I can try.
So POTS is a part of APOTS. There you go. Pakistan Ophthalmic Trauma Society.
So, Farzad, you document this one. So this was the date and time and date.
I'm going to invite Dr. Amir Rawan to stand next to Hussein Kakan, next to that new society that has just been launched on the December 10th, 2022. Farzad, can I take a picture?
That's done. So this, Farzad, this is the date, 10th December 2022, Pakistan Ophthalmic Trauma Society. This is Professor Hussain Ahmad Khan. This is Professor Amir Rahman. Be witness if you wouldn't find us after 72 hours.
Thank you very much, Hussein. That's fantastic, very inspirational. That's why I said he's the Messiah, the evangelist who made this meeting happen. With this, I'd like to introduce Professor Amir Rawan, who's going to talk about conflict-related injuries, and a very important aspect. A lot of developed countries actually are spoiled because their residents don't get trained in trauma because they are all funneled to apex centers. And
Right.
over to you, Amir.
So thank you very much. So I think conflict injuries, especially in this modern era, is very important. And especially recently, as you are hearing much about Ukraine, so what's happening there. But even if you look in Pakistan, so recently, there were like few years back, we were having a lot of bomb blast here, especially in our tribal areas, and a lot of the patients were coming with the injuries. And similarly, if we look at Afghanistan, which is our neighboring country, unfortunately, still they don't have good time. A lot of the patient don't get managed there. They come to Pakistan. That delays their either they had the primary repair, which may not be appropriately done, as we are already talking about no proper trauma surgeons we have got, so they present late. So it is increasing. So within a modern area, there are different explosive materials coming up like IEDs, and injuries can be very vast, involving the whole body, and eyes are not spared either. So it's different. Either it can be terror related, it can be war related. So different things can be happening. And there are different mechanisms when it's happening, especially in the blast injuries. Either the primary mechanism because of the blast wave that hits the eye, especially the organs which are filled with the air, they are more damaged. Similarly, the eye also get damaged. Glow rupture can happen. Or secondary problem can happen. Secondary mechanism means that because of the blast, whatever things are lifted up like dust, shrapnel, sand, different materials, and they can hit the eye, and before blink, it can just penetrate your eye and get into the eye, stuck in the lens, cornea, vitreous cavity, or the retina, or sometimes even subretinal space, it can go in. And similarly, tertiary mechanism is when the person who get the trauma and then hits some other, like fell down or hit some wall or something, then they get further trauma according to that, or something just goes in their eye. So we have to keep that in mind. And even in medical evacuations, we know that significant number of the patients are who are having ocular injuries. So we have to keep that in mind. So that's nicely shown in this cartoon diagram here. So primary, secondary, and tertiary mechanism. So different types of the injuries can happen. The gunfire injuries, that can happen direct injuries. Backfire you can do, or the fire can hit some place and then hit back to the eye, or even the blast injuries, which, as I mentioned, that it can be bomb blast, it can be explosive devices which are fit in there. And it's very difficult to have the protective measures for that, especially for the civilians. So I think classification, a lot of people have mentioned closed globe injury, open globe injury. So I'm not going to zones again. So we need to know cornea or limbal if it's involved, zone 1. If it's beyond that, up till 5 millimeter, it's zone 2. And if you go posterior to that, it's zone 3. Open globe, different mechanism. I think Dr. Tawfiq nicely mentioned rupture, penetration, intraocular foreign body, perforated or mixed mechanism. And similarly, in the closed globe injury, we need to know what exactly can happen. External and anterior segment, including conjunctiva or sclera. So that's considered as zone 1. Zone 2 means that the anterior segment, if like anterior chamber is involved, lens is involved, pars placatum area, or even zone 3, even posterior segment is involved, vitreous, retina, optic nerve, choroid, ciliary body, you can name it, so all can get affected. And here, closed globe contusions, lamellar lacerations, superficial foreign body, mixed. So coming to a few studies, like Iraq war study was a big example. If you look in early 2000, and eye trauma was contributing a lot at that time as well. And if we look at the US data, 800 medical records of Iraq coalition forces, either enemy prisoners or civilians treated by US ophthalmologists between this time period, 2003 and 2005, 73% of severe eye injuries were happening due to explosions. So quite a lot injuries. And about 13% of patients were requiring enucleation or evisceration, which means that you can't salvage the eye, you can't do the primary repair, you have to remove it. And that again is an important decision you have to do quickly to prevent the sympathetic ophthalmitis. So you have to decide that either you're going to salvage the eye or either you're going to take it out. If you compare with World War II and in Vietnam, to 20 to 50% at that time was, so they reduced due to protective measure, but still they are not gone. And similarly, intraocular foreign bodies, they are common. And the problem is that they can present delayed. It's not that at that time, they're not properly trained people there who can take it out. So initial repair, either it's done and they are then referred further for further management, and that delays up to 21 days. But luckily, it's uncommon to have endophthalmitis. Even similarly, I get a lot of the blast injuries from Afghanistan or our remote areas and you repair it, and luckily not endophthalmitis up till that time. So that's the data from Pakistan. If you look at the closed globe injuries here, so 49 eyes of the 44 patients, and 17% of the patient had other eye open globe injuries. So it's not only one eye is going to get involved, both eyes you're going to have them. And IEDs were contributing a lot, which means the roadside IEDs placed, somebody's passing through caravan or they get hit. And it is again important, non-ocular injuries are also happening in those patients. So it's not on ocular injuries, non-ocular injuries. And these were like vitreous hemorrhage in 16 eyes, superficial corneal foreign bodies, cataract, retinal detachment, commercial retina. So these were type of the injuries. If you look at the Syrian data, that is from the Turkish paper in which the patients or the people who are coming for the treatment from across the border, 224 eyes, and foreign bodies were detected in almost half of the patients. So 47% had foreign bodies. And these were either an orbital cavity, 50 patients, conjunctiva, cornea. But if you look at significant number in the vitreous cavity, around 44 eyes had in the vitreous cavity. And what were the material? Sharpnel was the common material, followed by organic material and the glass. So this is the meta-analysis of large number of the ocular injuries. We can see 13,777 patients. And majority of the eye injury is a modern conflict-related injuries. And US military has employed ocular protection, and they reduced it from 0.6% to 0.5%. But that again is a problem. If you look at the UK data from 2004 to 2008 in Iraq war, in spite of having all those protective measures, people were not wearing it, which means that again, that predisposed them to have the injury. And if you look here from 2003 to 2011, eye injury managed by UK military treatment facility were much less likely to be treated properly because of the lack of the trained staff. So this can be like condition. So that's a shrapnel from the bomb blast. Once you have taken out, it's lying outside. Or this was the patient who had a multiple fragments of the stones which hit the eye and the shrapnels, and cornea was completely gone. So somebody did corneal transplant, and then the patient was still not seeing. Then patient was roaming all around, and then was referred to me. And if you look in the vitreous cavity, multiple shining stuff there. So multiple foreign bodies have entered in the eye. All the vitreous was muggy. So I did vitrectomy in these cases, removed those bodies, and patient had some improvement in the vision. And unfortunately, this was the only seeing eye of the patient. Other eye was completely gone. So that's the case. If you look, there is a cataract here. There is an iris defect here. So you have to detect the things exactly. So if you have iris defect, you must be suspecting there is foreign body. So there is a posterior capsular rupture. You can see. And now I'm inducing a PVD, and that's a foreign body lying there. And it's very quickly, due to the blast, things happen, and it penetrates in the vitreous cavity. So once I have removed the vitreous, you can remove the foreign body. As we know that there is a posterior capsular defect there, so we can remove it via corneal incision. So which I'm going to do here. So once you remove the surrounding vitreous, you can also put the heavy liquid. Just if the foreign body is slightly heavier, or you're feeling that there is a chance there is damage to the optic nerve or macula, you can put heavy liquid and you can remove the foreign body. So you can use the forceps. I am just using the cutter. It's a very light one, so I'm holding with the suction. And once I'll hold with the suction, I'll lift it up, bring in the anterior chamber. And once it's in the anterior chamber, I'm using the forceps to remove this foreign. You try to avoid to drop it back there because it can hit the optic nerve or macula. So you just hold it, you can take it out and remove it. And then you can put the lens and finish up the case. So that's it looks like. So similarly, that's another case in which you can see the corneal sutures are placed in, or there was a corneal laceration which was repaired early. There was a cataract. Somebody already removed the cataract, and patient had a significant vitreous hemorrhage. B-scan we did. We noticed that there is a shiny thing there somewhere anteriorly. So here you can see I've removed the vitreous hemorrhage. There is some subretinal hemorrhage there as well, but I don't see any foreign body yet. If you watch closely, sometimes in the vitreous base area, that can be stuck here. And the problem is that the metallic bodies, if you won't remove, sidrosis can happen and the vision eventually will go away. So shortly you will see that the foreign body is just embedded here. So I'm gently removing the vitreous hemorrhage. And yep, you can see now. So once you remove it, you can, and sometimes it can fall down there. So once you have removed it, and you can take it out by using the forceps. And again, in this case, I remove through the corneal incision, holding it using McPherson. So I'll finish up quickly. Okay. So that's the next case. So this is a very interesting case. This one basically had 11 years ago, last injury. Patient had cataract. That was a defect. Somebody did iris repair. Big glass foreign body. Nobody removed that. Nobody bothered to have a look. Now he developed retinal detachment. Vision was reduced, and there was a break developed just close to the foreign body where it was lying. So because of the glass, it was not causing any inflammation or anything. So I removed this foreign body because it is pseudophakic patient. So definitely you have to make the scleral opening to remove it. So quite a large foreign body. So I'm opening up the conch here, making scleral incision. And you want to make it a large enough so that the foreign body can easily come out. And once I've done that, I'll remove it. So hold it by the forceps. Make sure you hold it properly in a proper direction so that you can remove easily. And now I would use my light pipe as well, just to support it from behind so that I won't drop it in and it comes out. And then I fix the retina by doing, so patient vision was hand movements. We just use the gas, and vision improved to 6/15 in this case. So patient did really well in this case. So I'll just quickly finish up. So I think it's very important to know about that the conflict or terror-related injury, they can be very unpredictable in spite of wearing goggles and things, especially for the civilians or people around. You can't predict it that something is going to happen. So these injuries can happen. And important thing is the timely recognition. You need to manage it timely primarily. And always suspect something. It's a vitreous hemorrhage. Always look at the fundus. If you can see it properly, you can see the fundus. If you don't see, please do the B scan and you will find out. Thank you very much.
Thank you. Thank you very much. And I think this is an important topic that is not oftentimes talked about. So really appreciate it. And finally, to complete the loop, we have a great talk by Professor Karl Golnick. It's a pre-recorded presentation. Unfortunately, he had to catch his flight on neuroophthalmic trauma. Traumatic optic neuropathy, we think a lot hasn't changed. And he's going to talk to us about what has changed and what hasn't. And he's got a little message for all us delegates.
Home in the United States. I'm sorry I can't be with you. My flights got switched around, so I recorded this short talk on traumatic optic neuropathy, what has changed and what hasn't. My objective is that when we're done, you'll be able to describe evidence-based treatment recommendations for traumatic optic neuropathy. The pathophysiology behind indirect traumatic optic neuropathy, and indirect meaning not direct injury to the nerve, includes different sort of postulates: transmission of force to the nerve itself, osseous compression of the nerve within the canal, and then energy absorption from globe displacement. So if the eyeball's moving, maybe that's somehow causing the energy to transmit to the nerve. You don't know for sure which of these is it. Maybe it's a combination of all three. Traditionally, over the last 20 years or more, the treatment options have included just observation, no treatment at all. Medical treatment is corticosteroids most commonly, more recently erythropoietin, and at least one study we'll talk about with levodopa, carbidopa combination, and then surgical optic canal decompression. And about 20 years ago, a little more than 20 years ago, this study was published. Not a very good study, a survey study. And really the results from this were that there was no sort of evidence-based recommendation on the type of treatment. You could do whatever you wanted. That led to this study some 20 years later that asked survey respondents, how do you treat traumatic optic neuropathy currently? So this was just published a year ago. You could see that most of the respondents were ophthalmologists. There were just several neurosurgeons, neurology, and so on. And about a third of the total, or the ophthalmologists, a third were neuro-ophthalmologists, and 2/3 were oculoplastic specialists. And what the study showed, and you don't have to read all this, but these bars are the different treatments. So black, observation, this hatching, steroids, the dark gray, decompression or steroid, and then just decompression. So the point of this is that it's all over the place, right? People are doing very different things depending, and there's not that much difference depending on what type of practice setting there is versus how many years out in practice. So at least in the survey, people are doing all sorts of different things. Fortunately for me in this lecture, very recently in 2021, this publication from a task force in the Ophthalmic Technology Assessment Group at the AAO reviewed the last 20 years of literature on interventions for indirect traumatic optic neuropathy. And they use this evidence hierarchy defined as level 1, well-designed and well-conducted RCT, randomized controlled clinical trial, level 2, well-designed case control and cohort, and level 3, case series and case reports. And they found no level 1 data on treatment of traumatic optic neuropathy, 6 studies level 2, and 26 studies level 3. In the next few slides, we're going to summarize those. And I don't have time to talk about each of these studies individually, but there are 3 slides with one slide with medical treatment. This is corticosteroids. And there were a variety of different studies. You can see there's only one level 2 at the very top. But if we eliminate the studies that had no controls, then we're left with these studies. And you can see in the results section column here, no significant difference compared to placebo, no significant, not significantly difference, better amongst observed than the steroids. And here's one better in the high dose steroid. So kind of a mixed bag for steroids alone. The next couple slides will be on surgical canal decompression. And again, if you eliminate the studies with no controls, we're left with these 2 studies here from Chen. And both of these studies really did not show significant improvement between the groups, maybe a trend towards better recovery with surgery. And another page of canal decompression. Again, we eliminate the uncontrolled studies and intervention did not improve. Here, treated patients did better than observed. No significant differences. And then finally, the last slide having to do with surgical canal decompression. Again, all of these from that same AAO technology assessment paper, eliminating the controls, the studies with no controls, no statistically significant difference. So that's for canal decompression. From the same paper, erythropoietin, there were 4 studies. The ones that didn't have controls, neither showed, the first study showed no difference. The second one, there was better recovery with erythropoietin. So not great data, only 2 studies, but perhaps something there. And then one study reviewed on levodopa, carbidopa, level 2, there's only 16 patients, 16 patients that got the drug, 10 got the placebo. They all got steroids, and the group that got the drug compared to placebo did do better in recovery of vision. So just the one study. So their summary was there's no level 1 evidence for any form of treatment of traumatic optic neuropathy. Study outcomes, as we pointed out, were variable. Corticosteroids benefit uncertain. Surgical intervention uncertain. Erythropoietin and levodopa carbidopa need further studies. So that's where they were as in 2021 when this study was published. Now, since then, there have been a few studies. This retrospective large study, all the patients received steroids. About 2/3 got canal decompression, 1/3 got steroids, found no significant difference in recovery of vision. This study, a randomized controlled trial of 30 patients receiving steroids versus canal decompression, no significant difference. A prospective interventional case study, 140 patients. You can see here 56 got the canal decompression, 44 got canal plus steroid, and 40 just got steroids. And their statement was that canal decompression was, quote, more effective visual improvement. I could not for the life of me just tell what that meant by the description in the study. So I'm not really sure what that means. There were another 5 studies reporting surgical improvements, but no controls, just surgical only, no control group reporting improvement after surgery, but again, not helpful. And then finally, a retrospective study of factors predicting visual recovery, 20 patients. This was to look at are there any other factors that help predict final visual acuity? And the answer was that when they looked at all of these things, imaging, demographic, et cetera, only the initial visual acuity was predictive. So what's changed? Well, I didn't mention, but way back in the early 2000s, a lot of us were using super mega dose steroids, the steroids from spinal shock studies. And then the crash study came out and showed that actually was bad and led to higher mortality. So we don't do that anymore. No super mega dose. What hasn't changed? There's still no good randomized controlled clinical trials. There's still no evidence-based treatment recommendations at this point. Now, I was also asked to give a brief perspective on an educator's perspective on ophthalmic trauma training. And there are a number of societies, as you all know better than I, that are involved with ophthalmic trauma. This society, where we're giving the talk, the Asia Pacific Ophthalmic Trauma Society. I couldn't find a lot about these various societies and what their initiatives are. The American Society of Ophthalmic Trauma has this on their website, a list of about 10 different things that they want to do. So you can see here trauma policy templates, call sheets, preferred practice patterns, and so on, national disaster, all of these things, but none of these are active links. I could not click on any of these to find out what are they actually doing. 5 and 6 on their list of 10 were mostly related to training at the AAO annual meeting. So they're apparently trying to establish a dedicated ophthalmic trauma section, trauma instruction and skills transfer courses, trauma paper section, and so on. And then a training and continuing medical education annual meeting, and so on, the One Network, a BCSC, and all these. But none of these are active links except the 3 there in the light green. And so I'm not sure exactly how well they're doing with these goals. One of my questions is there an ophthalmic trauma curriculum? I couldn't find one. There is, of course, the International Council of Ophthalmology residency curriculum, but nothing specific in this where the ophthalmic trauma curriculum is set aside. And my question is, well, why doesn't your society, why doesn't APOTS create one? This is something that I think you guys could do. You could base it on an existing curriculum. You could pull all the trauma parts out, see what gaps there are, and publish a APOTS ophthalmic trauma training curriculum. I think that would be reasonable to do with the experts in your organization. What about valid and reliable methods of assessing trainee competence in ophthalmic trauma training? Well, not much out there that I could find. I will say that we just published this ophthalmology surgical competency assessment rubric, the Oscar for Open Globe Surgical Management. We've published a number of these. This is the first one really directly related to ocular trauma, just published in Clinical Ophthalmology 2022. Some of you are familiar with these. Sorry about the very fine print, but the bottom line is these all looks very similar. This one has the steps of a procedure on the left column, the level of competence on the upper row, so novice to competent, and then importantly, a description of what activity you observe. So when you're done with a case, you simply circle what you see, hand it to the student, the resident, and then go over it with them. And hopefully, as they proceed from novice to competent, all those circled boxes go to the right. And when they're done with their training, they are competent at open globe repair. So I thank you for your attention. I'm sorry I couldn't be with you. That was not my intention. But airlines and flights being what they be. So have a great rest of the meeting and hopefully see you face to face in the future.
Thank you. I think that's a fantastic talk. I gave him two topics in one: traumatic optic neuropathy and education. And I think all of you who are managing trauma know that actually there's not very much evidence in a lot of the things that we do. And also there's no structure to the training that we all receive as residents and fellows. And hopefully today's presentation, he actually customized this talk just last night, putting it together for the AOCO 2022. So it's hats off to him. So I think we've had a great session. I know we've had long 4 days, and we tried to cover everything from trauma classification to trauma terminologies to pediatric injuries to conflict injuries, forming of a new society. I'm very happy, actually. Congratulations, Amir. So the founding member of the Pakistan Ophthalmic Trauma Society. And finally, the adnexal trauma, Dr. Farzad talked about it, and we talked about it. Any quick comments? Professor Sahaf, do you want to give one word of wisdom? How can we take ophthalmic trauma management in Pakistan to a higher level? I respect your words a lot.
I think Mike
He's got,
wants to come here.
yeah, he wants to come.
That's fine. On कर दीजिएगा.
Thank you. Most of the ophthalmic trauma that ends up in our emergencies, and they are being run mostly by the residents, senior registrar or registrar, and many a times they plan the patient for the normal list, and then it's done by the senior consultant. And with the vitreoretinal services coming up, the standard has become much better. It only needs sort of sorting out and organizing. And the material is there, the personnel are there, only a bit of training on particular lines, and it would be wonderful. There's a lot of material, and with the coming up of oculoplastic surgeons and then vitreoretinal. First, when it was a globe injury, it was presumed that the eye is at least gone. We are just talking of cosmetic and all that. But now the vitreoretinal are doing a lot of things, yes. We see many good operations, good cases. So all it needs a bit of organization, yeah.
There you go. You heard it from him.
Same thing we were discussing what you have told.
Why don't you tell him what you discussed? Yeah.
Yeah. So, Dr. Imran, we were already talking about these things. So brilliant. You said the same things what you were thinking about that we should do in Pakistan, and we are planning to create a society, Pakistan Ophthalmic Trauma Society, so that can help educate the people and we can manage the trauma better. So, and we will definitely take your words and advice.
It would be really useful if we engage the young ophthalmologists.
Absolutely, yes, that's the plan to do.
Those persons who are the man behind the gun.
Absolutely.
They are the ones who, if we just do it at the highest level, they feel left behind.
Absolutely.
Those who are doing it, they feel left behind. So they should be taken into.
Can I kindly request your support? We have young people who are actually formed a new society. We need your mentorship and guidance and see how we can take it much higher, sir. We need your blessings and support.
I can pray for them.
Yeah, thank you very much, sir. So thank you very much. I think we had a great session today. I know everybody has to go for other commitments. I think today was a very important session for this part of the world, and I think with Dr. Ramiz here now representing Syrian ophthalmology and Arab ophthalmology, we hope the formation of ophthalmic trauma specialty interest groups and eventually forming societies both within countries and beyond countries in the region, whether it's Middle Eastern or whatever it is. I think that's the way to go forward and involving all subspecialties. Would you like to make any comment? Yeah. So thank you very much, and see you all this evening and then tomorrow. Thank you very much.
Sitting in the audience or something. I was sitting on